This morning, we're just going to review some of this stuff. I'm not going to get into the specific criteria of each one of the shapes. Like I said, that's up on the website. You guys can go through, you can look at that. I don't remember if I put the manual up on Blackboard yet. I did? Okay. Thought I did it when I was sure. All the criteria for the shapes that we're looking at and the critical shapes profile are up there. These 6 shapes, these 6 setups, set up then shape, go right into each one. And it talks about the specific criteria for each one here. So we have to keep in mind, and I do want to spend a little bit of time talking about why we would even consider doing these. First and foremost, for the comp, and for the patient that walks in with random whatever going on, random back pain without a mechanism, random knee pain without a mechanism, for that person, we're using this as our entry point into our assessment to create a profile of movement to determine what we need to do next. And why I say we start with this. This isn't something that somebody comes in with knee pain, we've already gone through and looked at a lot of things, and we just look at this because we wanted to assess movement. This is our entry point. And for a lot of people, they're like, okay, I'll use this, but I'm going to use it later on. Well, if you do it any other point in time, you've now gone outside of what the intent of this is. Because that person comes in with knee pain, what are you going to do first? If you're not going to do the shapes, what are we going to look at first? Let's be honest. Somebody comes in with knee pain, we're going to assess their knee. Group project. Who's the problem? The person complaining or the person that's not doing the work? And that person complaining is overworked, and that's why they're complaining. Remember, if they're coming in and they don't have a mechanism, we know that the knee is complaining. The knee is where the symptoms are. We don't know what's causing that. So if somebody comes in with knee pain and we jump right to where the problems are, where the symptoms are, wonderful. We knew their knee hurt before. We know their knee hurts now. You just spent 15 minutes going through stuff. What new information do you have? Nothing. So we can bypass that because we know we're going to find stuff at the knee. You palpate the knee, you're going to find things that hurt. We might find range of motions that are limited. We might find some other stuff going on. We know that because they're telling us their knee hurts, but we don't know what caused it. And this is where if we see somebody sprain their ankle, if somebody has the mechanism for spraining their ankle, we know we need to check the structural integrity because they have something that could have damaged the structure. Somebody comes in, I stepped down and I rolled my ankle, I'm going to assess that. I need to look at the structure. Somebody comes in, my knee hurts. Okay, when did your knee start hurting? Well, I was playing football and I got tackled and it's hurt ever since then. We have a mechanism. But if it's my ankle started hurting, when did it hurt? I don't know. It's just progressively gotten worse over the last couple weeks. Or my knee's been killing me for the last month. I don't remember doing anything to it, but every day I wake up, it hurts. We don't know what caused that. We have to consider other things. So our entry point is going to be, we need to get an idea of what their movement is. Because you assess that person's knee on day 1, they complained of knee pain. We found things, it's not a surprise. We don't have any new information out. What are you going to look at next? Are we going to look at the hip? Are we going to look at the ankle? Because old school, when I was sitting in the desks that you guys were sitting in, we didn't have the fancy tables, we actually had desks. It was, well, if they're in with knee pain, you need to assess the hip, the joint above, and you need to assess the ankle, the joint below. Not wrong, but that was 20 years ago. We need to take a couple steps further forward. And why are we assessing the hip and the ankle? Just because it's the joint above and below. If somebody comes in with hip pain, we're going to assess the knee and the lumbar spine. Somebody comes in with elbow pain, we're going to assess the shoulder and the wrist. But why? And why just those two? Because there's several instances where if I have knee pain, the reason I have knee pain could be because of my upper extremity, could be because of my neck, could be because of my opposite foot. I'm never going to look at the opposite foot on somebody that has knee pain because there's no textbook on the planet that says somebody comes in with knee pain, look at the joint above and look at the joint below, and then also look at the foot on the opposite side. There's no algorithm that points that stuff out. So we have to have something where our clinical skill and our clinical experience and our critical thinking can identify this. This is why when we have these individuals with no mechanism, the first thing we need to do is get an idea of their overall movement behavior. Critical shapes can allow us to do that. Because once I look at the critical shapes, then I decide what's the next thing I need to look at. And maybe it is their knee. Maybe the biggest issue in how they move and their movement behavior is their knee, and I need to look at that. But maybe it's not. Maybe it's an upper extremity. Maybe it's their neck. Maybe it's something on the opposite side. I'm not going to know that if the first thing I jump right to is looking at that knee. So when we don't have a mechanism, they don't have a reason why their pain began, it's been something that's been going on forever, we have to get an overall idea of their movement first to determine our next step. Now, outside of the comp, if I want to answer the very specific question, should I add external load to this? Should I add stress to this shape, to this position? I want to look at some very specific setups, very specific shapes. If I want to know, should I load the strategy, which is going from a bottom and deadlift to standing, which is 2 coordinated weight shifts, or a deadlift. If I'm wanting to have somebody do deadlifts, I need to make sure that I should load them and that they have the static positions before I move forward. We're running into a situation now at Mercy where we have a post-op. I'll float this out there for you guys and tell me what your logic says. Post-op hip patient, non-weight bearing. So they're on crutches all the time. The reason they're non-weight bearing is because the physician we can move the hip, so we can flex and extend the hip actively and passively as long as they're not loaded. So the patient can literally do this. The physician doesn't want them doing this, where there's compression and shear. So we can either flex and extend, or we can just stand there statically. He doesn't want any kind of compression and loading at the same time, okay? So they're non-weight bearing. So doing a chart review, and I see in the chart that the clinician has them doing some stuff standing up. Okay, that's fine. We're not violating any restrictions because we're in standing. We're not moving out of this. Well, then it goes on to say that they had them going in and out of the bottom of a deadlift. So going from here, they were doing unloaded deadlifts. They were working on hip flexion. Okay, so from what I've described, what red flags jump out to you? We're doing the exact thing that they said not to. Seemed like a problem. Now, the justification is, well, they go back to see the doctor tomorrow, and tomorrow's a 6-week mark, and we just wanted to make sure that when the doctor said they could do this, they were ready to go. Be honest, if I'm in that situation, I might consider doing that same thing. But here's the situation. At this point in time, with what that clinician did, if the physician comes back and says, I have a problem with that, you have now operated outside of our clinical philosophy. You've operated outside of all of our safety nets. Because all they did was they had them stand up. Their logic wasn't flawed. And we're talking one day, but they had them going from here to here. And they just had them cycling through. Now, physician comes to me, Brandon, do you agree with this? I have to, at this point in time, say, no, they should not have done that. The logic is there, your restrictions are there, your restrictions trump the logic. They have no reason why they should have done that. They're on an island. They don't have any support from the department right now because they chose to operate outside of our safety net. Now, here's the safety net. If they would have said, well, they see the physician tomorrow. I looked at them in standing. Everything looks fine. They're not shifting their weight. They're not favoring that. We used a box to offload their upper extremity weight to get them out into this position, and I put them in bottom of deadlift statically, because now we've gotten here, we've compressed, but we're not shearing. We've unloaded everything to get them there. I put them there, and I looked at the bottom of deadlift, and they met all the criteria. So we chose to go back and forth between them. That situation, they've now looked to make sure that statically everything was here. They look to make sure statically everything is here. And they've checked the boxes. Because in that instance, I can say to this physician, everything looks good. I think they should be doing this. They see you tomorrow. Is 24 hours really that big of a deal? He's going to say, not really. It's just when they got scheduled. And if you check the box and you think they should do that, we're fine with it. It's that one little step. Should they? Because if I don't check that, and now instead of cycling through this where their weight's where it's supposed to be, now what if they're all cockeyed and doing all this weird stuff? Now we don't know exactly what's happening. They're moving all over the place. So we can determine, should or should I not load this strategy? Should or should I not have them go through this unloaded strategy to stay within good clinical judgment? Now, well, you could say, well, I was watching them go through that. Okay, watching them. Why? What are you looking for? How solid is that? And you can play devil's advocate. Well, how solid is if I profile them here and profile them here and say, yes, they should. How solid is that? Well, we at least have criteria that are established and have been looked at and over the years have stood up to the test of time and to some scrutiny. That's a little bit more than you, and I'm specifically talking to you guys as GAs, in your 1 year of clinical judgment. Now, if you are clinicians that have been practicing for 30 years, that's a lot different clinical judgment. But unfortunately, you guys can't have that discussion with me for another 29 years. I'll be honest, we're not going to have that discussion in 29 years. So one of the benefits of this is we can now allow individuals that don't have a massive amount of clinical experience and that eye for movement, here's the very specific criteria that you need to look at, just check it. And so now you have a footing compared to that person that has been practicing for 15, 20, 25 years. You can start to look at things right away. So those are the only three intents. Profile movement, determine should I load a very specific position and should I load a strategy. Now, one of the things, I want to come back to this word profile for a second. Things important to understand that because there's a specific reason we didn't call this a screening. There's a specific reason we're not calling this an assessment. There's a specific reason we chose to call this a profile. And as soon as I said we were going to call it a profile, I knew we were going to run into just a little bit of pushback because we're taught we shouldn't profile. Profiling is bad. Profiling is wrong. And I don't disagree with that. But it comes back to what are we profiling and what is the intent? And the other thing is, we profile people every day subconsciously. 7 o'clock tonight, you're at the mall. You're walking from Macy's to your car. You see me in my black jacket walking across a parking lot, and I look like I have a hate the world scowl on my face, which is my otherwise normal face outside of here. This is my warm fuzzy face. But I have my hate the world face on. You're walking to your car, I'm walking straight at you. Are you going to walk right by me? Are we going to pass each other? Are you very politely, while we're a little bit of a distance away, are you going to slowly change your angle to the other side of the lane and walk on the other side of the lane of cars? Now, you see Tanya walking, exact same situation. You see Tanya walking towards you at night. Are you going to shift over or are you just going to walk by her? We profile. And why do we do that? Because it works. Now, I do agree, it comes back to what are we profiling and what are we profiling for? And we've all seen in the news and other things, when we profile on race, when we profile on gender, and it's not we're trying to help somebody, we're trying to punish somebody. I completely agree with the stance on profiling like that. But what we're looking at here is we're looking at movement, how that person moves with a very specific intent to make some assumptions essentially that we're then going to try and prove or disprove with our further testing. So we are creating an overall profile of movement to see what we think might be going on. And that is the ultimate problem with profiling because we're making a lot of assumptions. But with this, what we're doing is making assumptions. And at the end of the profile, we're not done. We then take our next step and we look at other things to either confirm or deny what we saw so we can get to the root problem. We're not going to base, and here's the other thing, we're not going to base any of our interventions off of just the profile. If you do that, I don't agree with how you're using this. Okay? So we finish the profile, we have some assumptions. We're going to confirm or deny those assumptions with further testing, and we're going to base our interventions off of the further testing off of the profile. It's not a screen. You go to the eye doctor. First thing they have you do, or they used to stand up and used to look at the little thing hanging on the wall. Now you look at the electronic thing. But there's always a big E on the top of the eye chart, the Snellen chart. You went through, you looked at that. If you did fine on that, you moved on. If you didn't do fine on that, you got further testing. That's a screen. If you pass the eye chart, they'll do a few other testings, but if you fail the eye chart, you're getting more testing. That's a screen. When you go to the doctor and they take your blood pressure. If your blood pressure is high, that's a screen. They can't tell you what the problem is. That just tells you that we need to do more testing. So they identify that there is a problem. You have a problem with your eyes. You have a problem with your cardiovascular system. We're not calling it a profile we're not calling it a screen because when we finish the profile, we're not saying there's a problem. We don't know if there's a problem. We just know there's things that we have to look at. It's not predictive. And when I say predictive, it's up there twice. We're not predicting what a person can or can't do. I've had several people that when we get them into the bottom of the bottom of their deadlift looks like absolute trash. Standing looks like absolute trash. They stand over top of a bar, they do a deadlift, and that deadlift is textbook. Based off of the fact they failed the bottom of deadlift and they failed standing, they shouldn't have been able to put that strategy together, but they could. I've also seen people where standing looks pristine, bottom of deadlift looks pristine. You have them stand over a bar or a kettlebell, and it looks like a dumpster fire. What happens next? Based off of their static shapes, it looked like they should be able to do it, but they couldn't. So it doesn't predict what somebody can or can't do. That's one of the problems with us dealing with humans from a rehab standpoint is we can do a lot of things. We find a way, our nervous system is the most adaptive nervous system on the planet. We find a way to do things. So we can't really predict what can and can't happen. All we're saying is that what should or shouldn't happen. Should we load this or shouldn't we load this? We're not predicting injury. We're not saying somebody failed bottom of deadlift, they're going to have low back pain. We're not saying, well, they failed the bottom of the lunge and the crouching Chang, that person, they're going to tear their ACL. We're not saying that because, again, it's not predictive. And most importantly, it's not identifying a problem. It's not identifying the pain. It's not identifying the cause. We're using the profiles to point us in a direction to get more information. It just says, hey, look here. We need to dig a little bit deeper. There's something going on here that's a little bit different. When we talk about the predictive side, I want to go back, I want to take a second and talk about the FMS, Functional Movement Screen. Have you two heard about the FMS before? Okay, we talked about the FMS just a little bit last year. So I want to talk about the FMS for a second, not to compare and contrast, but I want to look at what the research has said on the FMS, very specifically in regards to prediction. Because the logical step is, well, we're looking at movement, we're creating a profile. If you have a profile, we can predict what people can and can't do. We can predict injuries. That can't happen. FMS research is very supportive of that. FMS has been around since the late 90s, very well established. Use it at the NFL Combine, use it at the baseball Combine, they use it all over the place, at every different level. 2021 study does not discriminate who suffered, those who didn't suffer injury, does not support the FMS as an injury prediction tool. 2020 study, composite scores asymmetry were more useful for estimating injury risk in senior athletes compared to junior athletes. Not the overall FMS, just is there a difference left side to right side? So we can kind of get an idea if there's a difference left side to right side, but still doesn't support it as a prediction tool for injury. 2020 study, FMS scores correlated to higher PT testing scores as the absence of tobacco use and the absence of any musculoskeletal injury. So it correlates to how people move, but not, again, predictive. Doesn't demonstrate properties essential to be considered as a movement scale. It is neither a measurement nor predictive. It has neither measurement nor predictive validity. Now, I'm not throwing this stuff out just to throw the FMS under the bus. Meta-analysis, they looked at lots of different things. Again, neither one supports that there's any predicted value in the FMS. We looked at a couple other studies. 2007 study by Kiesel. Study suggests fundamental movements measured by the FMS is an identifiable risk factor for injury in professional football players. This 2017 study, excellent intra-rater reliability. Those with a score less than a 14 had a higher likelihood of injury. So we can find some studies out there that support it as predictive, but the number of studies that support the FMS as a predictive tool are significantly fewer than the number that say it's kind of sketchy as a predictive tool. This isn't to throw the FMS under the bus. I do want to point out, though, with that 2007 study, this was the first one that showed the FMS, or this is one of the first ones that talked about the FMS in a predictive manner. Two of the authors, Kiesel and Plisky, both are FMS instructors. So you kind of have to take what they found with a little bit of a grain of salt, because if we call it predictive, that's good for FMS. Now, I will say, when we talk about injuries, one of the reasons the FMS isn't predictive, one of the reasons we're not talking about the movement profiles, the shapes of movement as predictive, is when we talk about an injury, injuries are multifactorial in nature. They're very complex. You can there's a picture from a couple years ago of a Texas football player that got tackled, and his face he was laying like this on his back. He was getting tackled, and his face was in the ground, like cervical hyperextension. And you see it happen, and the announcer's like, oh, and you're watching it, you're like, oh, and the pile starts to unwrap itself, you're like, he's not getting up. And he pops right back up and goes to the huddle. Like, how in the world did that happen? You know, we see things where you're like, yep, that's going to be an injury, and they pop right back up. Or we see things like, oh, that wasn't that bad, and it was traumatic for that person. So when we talk about injuries, how somebody gets injured, the factors that cause that person to actually sustain an injury are so broad sweeping that we can't predict what is going to injure somebody and what's not going to injure somebody. And if we can't even decide on the definition of what an injury is, because if you look at any studies on injuries, one of the first things they're going to do is define what an injury is. And a lot of these meta-analysis, a lot of the articles are thrown out because this study looked at injuries and defined injury this way. This study looked at injuries, defined injuries a different way. We have to throw that one out because their definitions aren't the same. We can't even decide what an injury is, so we can't really assign predictive values to these other tools. This is Greg Cook. He's the one that developed the FMS. In Gray's defense, we've had this conversation a couple times because I've asked him this question a couple times. He's like, I never said it was predictive. People started using it. Researchers started looking at it, and all of a sudden now it's getting thrown in as a predictive tool. He's like, but from the onset, he's like, I never intended this to be as a predictive tool. We just wanted to look at movement. Now, that's his stance. As an entity, as an organization, FMS, these articles that talk about FMS as a predictive tool, they haven't really done anything to counter that, but they don't market it as a predictive tool. So researchers are using the tool incorrectly. Which again, kind of using this as a model, I want to make sure that you guys aren't using this tool incorrectly. When we run somebody through this, remember, we finish the profile. We're not ready to do anything yet other than continue our assessment. You run somebody through the 6 critical shapes. All it's saying is, look here. We need to do more information. We're using a series of prescribed movements that are based on how humans are going to need to use their body day-to-day activities. We can assign that to the skills of being human. We can correlate that to activities of daily living. We can see similarities in what people do in the weight room from a training standpoint. We can see similarities within sporting skills. But the shapes aren't sport specific, they're not ADL specific, they're not specifically looking at one or two things. We're just looking at how the body is moving in day-to-day life. So we can't, when we see that, we can't blame the position. So what I mean by that, again, going back to next week, we're going to be talking about clinical priorities. And one of the things you won't see on that clinical priority sheet is the bottom of lunge. You have that patient with knee pain, you run them through the critical shapes. All right, wonderful. What do you think the problem is? The bottom of the lunge is the problem. No, it's not. Because remember, you finish the profile, we're not ready to treat. We're not ready to assign what the problem is. We can't say the bottom of the lunge is the problem because the bottom of the lunge is pointing us somewhere. We don't know what the problem is. If you tell me that the bottom of the lunge is the problem, what you're telling me is you haven't finished your assessment. You haven't figured out what the problem is. It's just saying that the bottom of the lunge is the problem. It's just like saying Griffin's knee flexion is the problem. Can you treat that yet? No, we can't. We don't have enough information because we don't know what's causing that issue. We don't know what is causing the problem in the bottom of the lunge. We just see that it doesn't meet our criteria and we have to move forward. Guy loves Gordon Ramsay's idiot sandwich from Hell's Kitchen. We're not going to stop at the bottom of the lunge. We're going to continue to look on and see what the other issues are. So as we're going through this, as we're running somebody through our shapes profile, we're doing two things at once. We're multitasking. As we're going through, we're looking at all the criteria and we're determining did they meet the criteria, did they meet all the criteria or not. If they meet all the criteria, they pass that criteria. If they don't meet all the criteria, they fail that criteria. While we're doing that, what we're also doing is we're looking overall. It's almost like we're having an out-of-body experience as we're taking this person through the profile. I'm right here taking this person through the profile, but I'm also standing back 25 feet looking overall at how this person's moving. I need to see did they fail the criteria, but I'm also looking at it from a distance. What's the biggest thing that's going on there? What's the most obvious thing? What's the most consistent thing that jumps out to me about how this person's moving? We're looking for what stands out. This is where your clinical skills, this is where your clinical experience starts to come into play. What stands out to you? What do you notice? When you finished with the shapes, what questions does it leave you asking? Because those are the questions that you need to answer. When I was taking Kaylee through, every time we put her into a position where her hip had to flex, if every time we put her in a shape where her hip had to flex, so bottom of deadlift, bottom of lunge, crouching Chang, if every time we put her in that position where that hip had to flex, if we saw something, the commonality is every time we asked that right hip to flex, she had to do something weird. She had to change how she aligned things. She had to change her orientation to accomplish that task at hand. The biggest, the most obvious, the most consistent thing is her right hip. We could say right hip flexion. I don't want to blame the right hip. I don't want to blame the ability to flex the right hip because we looked at that in a symmetrical stance. We looked at that in an asymmetrical stance here. And then we looked at that in an asymmetrical stance here and here. We looked at hip flexion 4 different ways. We can't say what the problem is. We just can say that we looked at hip flexion 4 different ways, and all 4 ways she had to do something a little bit on the weird side to accomplish what we asked. I need to look at that right hip. Or you could take it a step further. Well, if we're talking about the hips, how do we know what she was doing on the right hip wasn't because of the left hip? You're absolutely, it could be. We could say pelvis. We need to look at what the pelvis is doing. How does the hip on the right side flex to an extent? How does the hip on the left side flex to an extent? What do the rotations look like? What does the pelvis look like when it's symmetrical, asymmetrical? What we've done is we've now taken that movement profile and we've started to we've narrowed it down to a specific region of the body, where we can then start to look at ranges of motion, do occupation, do other stuff. When we talk about scoring, for the comp, all you have to do is determine pass or fail. From a clinical standpoint, when we utilize this, there's 2 ways to pass. We call it C1 and C2. That's just the nomenclature we have assigned with this. Capable and competent. Because there is a difference between how somebody passes. If you fail it, I don't care why you fail, you fail. it doesn't matter why, you just don't pass it. So there's only one fail. You don't meet the criteria. But if you ask somebody to get into, we'll do standing. I need you to stand with your feet hip width apart, toes pointed straight ahead. I'm there. I heard your instructions. I interpreted your instructions. I aligned my body exactly how you said. I pass. Now, rewind, and you say, I want you to stand feet hip width apart, toes pointed straight ahead, and I'm standing like this. Does that look like how I looked just a second ago? No. Are my feet kind of hip width apart? Kind of. Can you narrow? Your feet are a little wide. That's more shoulder width than hip width. Can you narrow your feet up just a little? Oh, sorry. I thought that was hip width. Okay, wonderful. But now your right foot's good. Your left foot's not straight ahead. Oh, it feels like it's straight ahead. Well, can you straighten it up to where? Can you bring your toe over and touch the dowel? Oh, sure. How does that feel? Well, it feels like I'm standing all pigeon-toed. Well, that's feelings are irrelevant right now. I was able to verbally coach them into the position. Now, this feels like for that person, they're standing like this because this is narrower than what they thought hip width was, and straight ahead feels like it's internal rotation, but we were able to coach them into this position. They got here, it just took a little bit of work. That's a lot different than saying, hey, I want you to stand feet hip width apart, toes pointing straight ahead, and they go right to it. So we have to separate those two. So if you say, I want you to stand feet hip width apart, toes pointing straight ahead, and they go right to it, it takes no coaching. That's C2, they're competent. They express a high level of competency with that. If you have to coach them into the position, they're capable, they just can't recreate. Because what's going to happen is you have them do a couple things. All right, I want you to go back to that feet hip width ahead, toes pointed straight ahead position. They're going to go back to what they feel is what we're asking. This is an awareness issue. I can coach them, but it feels weird to them. That's a lot different because from a clinical standpoint, from a clinical standpoint, why that's important, if somebody gets a C2 on this stuff, I know I can say, I want you to stand feet hip width apart, toes pointed straight ahead. I'm not going to have to invest a lot of time and energy double checking and making sure they have that. I can worry about coaching other things, more complicated things. But if I know that they're C1, okay, I really have to pay attention to making sure that we actually get you here and that we're keeping you straight ahead while we're doing anything. I know that I have to be more engaged on the coaching side of the position, not necessarily moving into some of the other things. So it gives us an idea from a coaching standpoint, from an intervention standpoint, what we need to pay attention to. Again, if they fail, it doesn't matter why they fail. They just don't meet the criteria. And the last thing is pain. Pain, passing, and failing are separate entities. If somebody has pain, that doesn't mean they pass. If somebody fails, that doesn't mean they're in pain. Somebody can pass and be in pain. So when we look at this, they can fail, they can be capable, they can be competent. Or they can fail with pain, they can be capable, they can pass with pain, they can be competent with pain. All of those tell us different things. We're going to score each one individually. If somebody fails, now we start thinking about, as soon as I see somebody fail a shape or miss a criteria, now that kind of turns on my spidey senses for what happens moving forward. If I see somebody and the reason they fail is because they have valgus on one knee. If I see them, this is their standing. If I see this, do you think I'm probably going to be paying attention to what their knee's doing when we get to bottom of deadlift or bottom of lunge or crouching jack? Absolutely. I want to see, is this just a random thing they do here? And then all of a sudden when I flex, it goes away? Or is it something that only happens when they're in symmetrical stance, but as soon as they go asymmetrical, it's fine? As soon as I see they fail something, I want to make sure I'm paying a little bit more attention to that. I'm more sensitive to that in the other shapes that involve that same criteria. Again, I want to look at, is the reason that they failed these shapes, is there one specific body part or joint that is in common with that? Did they fail bottom of lunge? Did they fail bottom of deadlift? Did they fail standing because of what was going on at the ankle? Or was the reason that they failed kind of all over the place? I want to look for those commonalities because again, at the end of this, we need to take that next step. That next step is going to be either a region or a joint that we're going to go and get more information. I would caution you when you're looking for these commonalities to say again that it's a hip extension problem, or to specifically say they can't extend their hip. Now, if you say that and every time you looked at hip extension, they failed it, okay, that's one thing. If they, in standing, they can't extend their hip. In the setup for back rack short overhead, they can't extend their hip. In bottom of lunge, they can't extend their hip. You can probably at that point say it's a hip extension problem because they failed it every single time. And how I would actually say that is they're lacking hip extension in every way that we looked at it. Now, if they only failed one shape, if there was only one criteria they couldn't extend their hip, you can't tell me it's a hip extension problem. Because I can tell you out of the 5 times we look at hip extension, 4 times they extended their hip, 1 time they didn't. 4 is greater than 1, it's not a hip extension problem. So we have to be very careful and protect our thought process with this, because if we immediately say it's a hip extension problem, now we're biased to finding a hip extension problem later on with our further testing. Versus, I think there's an issue with the hip. I need to investigate the hip. When we looked at the hip, it had some problems extending in a couple of our shapes, not all the shapes. So I don't think it's a true hip extension problem, but they extend their hip just a little bit weird when we ask them to be in an asymmetrical stance. But it's a hip issue or a pelvis issue. If they fail with pain, so if we're going through the shapes, if earlier when I was running Kaylee through the shapes, we got to back rack, and as we're going through back rack, we get here and I kind of see her wince a little bit. Hey, you're wincing, what's that mean? My shoulder's just a little, I feel that in my shoulder. Does it hurt? It doesn't feel good. Now, we can go, you can ask them, is it a pain, is it a stretch? You can try to delineate what it is. It doesn't matter because remember, pain is a subjective experience. I can express it to you, it just feels like a stretch, but if you were experiencing what I was feeling, your shoulder's blowing up. So anytime we see that, we can try to get more information. Is it a stretch? Is it a cramp? You can try to get all of that. That's all fluff. It doesn't necessarily matter. The only question we need to ask, do we need to stop or do you want to continue? Because if they say, kind of hurt, I kind of feel something in my shoulder. And I ask the question, well, is that more of a stretch or is it a pull or is it pain? How would you describe it? It's a stretch. Okay, we're fine. How do you know a stretch to them is what a stretch to you feels like? Again, it's very subjective. Now, if they say, yeah, it feels just like a big stretch, do you want to continue? No, I need to stop. Okay, we're done. If I saw enough in the setup for back rack, I'm going to determine if they met the criteria or not. If I didn't see enough, guess what I do? I failed it. If we're here, this doesn't, she winces. Do you want to continue? No, I don't want to continue. Okay, we're not going to look at the setup for back rack anymore. We still need to look at the shape. Now, traditionally, when we look at the shape for back rack, we start here and we go from here to here. We know this is uncomfortable. We're not going to put her back here again. So what we're going to do, I know I'm going to move as we move forward. We didn't like this position with her shoulder. Here is very similar. So I know going forward, I need to be a little sensitive to this. What we would do is, hey, can you take the dowel key, set it across the back of your shoulders? Yeah, I don't care how they get there. And then I'm going to adjust, make sure that things are kind of centered. And again, I'm looking for I'm looking for any signs of pain in that shoulder. Surprisingly, you'll have people that this doesn't hurt, this does. This hurts, I'm going to fail them. Do you want to continue? Or this hurts, do you want to continue? I failed. If they say I need to stop. If they're like, yeah, this hurts, but I want to keep going, I'm going to mark it as pain. I'm going to mark both as pain, but then I'm going to go ahead and try to get a good idea what's going on with this shape. We're not going to immediately stop. But if she says, yeah, I don't want to continue, we're going to stop. Go on to back rack. Can you get into this position? This really kind of hurts. Okay, we're done. You fail. Or hey, I'm going to need you to take the bar and set it across your back. I don't care how you get it there. Do you think you can do that? I'll try. And if they try and they get it, wonderful. We'll score it as we see it. But if they say, no, I don't even think I can get it there, wonderful. We're going to fail and move forward. What I don't want you to do in the setup, this hurts, I don't want to continue. You don't look at back rack, setup, and then you neglect the shape. So if they fail the setup, that doesn't mean we automatically don't do the shape. It means we stop what we're doing. Hey, here's what I need you to do on the next part. Do you think you can do that? Or do you want to continue? If they say they want to continue, at any point they can stop. If they say, yeah, I think I'm fine, and she's all hiked up like this, and I'm like, okay, well, I need you to get that elbow down a little bit. Yeah, I think I need to stop. Okay, we're done. Okay? If they're in pain, the choice to move forward isn't ours as a clinician. It's theirs. If they say, yeah, I want to continue, we go on. If they say, I need to stop, we stop. If they say we need to stop, that doesn't mean that we completely neglect the shape if we're on the setup part. We're just more sensitive as we move into that. And if they say they don't want to try the shape because they think it's going to hurt or they're afraid of how it's going to feel, then that's their choice. We just fail and move on. Because we have the information that we need. We know there's something going on in that right shoulder to the point that we had to stop back rack. They don't feel comfortable in going forward into the actual back rack shape. Let's see what it looks like here. Hey, now I'm going to put you here. How does this feel? This feels fine. Okay, can you think you can take the dowel and set it behind your neck? How does that feel? It's not bad. It's a little tight. Okay, do you want to continue? Because now I'm a little bit more sensitive because we had to stop one test because of how the shoulder felt. And it's a little tight here. Do you want to continue? Yeah, I'm fine here. It's a whole lot better. Okay, now I need you to lift your elbows up. Do you think you can do that? Yeah, I think I can. How's that feel? It's really tight. Well, do we need to stop? No, I'm fine. It's just a really big stretch. Do you want to stop? No, I'm good. We let them make that decision. We're more sensitive to it. We're using the information that we know to help us as we move forward, but we're making it completely up to them. Now, in that situation, this hurt. I felt like I could get here. They could get here. We get this person here, they feel a stretch. Are we worried about a structural problem in that shoulder? Yes or no? No. Why not? Because we just looked at orienting the shoulder in some degree of flexion and rotation 4 different ways. If somebody has a rotator cuff tear, do you think all 4 of those are going to be uncomfortable? Absolutely. If somebody has shoulder impingement, do you think all 4 of those are going to be uncomfortable? Absolutely. Somebody has a labral tear, do you think all 4 of those are going to be uncomfortable? Absolutely. But if somebody only has pain in one of those, do you think structural issue is jumping straight to the front of our head? Not necessarily. Because if it's a structural issue, it's always going to be there. That labrum's always torn. That meniscus always has a tear. If it's not a structural issue, we're going to get inconsistent issues. We're going to get inconsistent feedback from that person. That's why dealing with non-structural issues is so complicated and confusing, because we get inconsistent issues with that. That's wonderful. It rules out this. It lets us not jump straight to thinking that it's a structural issue. Why is that important? Because when I finish, if that's the only thing we found, everything else was pristine. The only thing we found was what we experienced there in back rack and short overhead. My next thing isn't going to be a special test to rule out labrum or to rule out rotator cuff. I might go to palpation, or I might go to range of motion testing. Bless you. I might do manual muscle testing. Now, ow, that hurts. I'm sorry. Ow, this hurts. I don't want to continue. Do you think you can get here? Nope, that hurts too. I don't want to continue. Yeah, that hurts too. I don't want to continue. Do you think you can get the dowel here? Nope, can't even get the dowel there. Guess the first thing I'm going to be doing on that person is I'm going to do one of the special tests that we learned in upper body assessment, because now I'm thinking that I've got a labral, I've got a rotator cuff, I've got some impingement. I need to rule out those before I do anything else. But if I don't have that consistency, special tests aren't completely off the table, but I'm moving there. It's not going to give me the most information. It's moving down my list of priorities. It might be something that we look at tomorrow or the next day if I don't have time to do it today. So now, that person that comes in with shoulder pain, Just that little sequence right there, back rack and short overhead, helps us prioritize what things we need to look at, or if we even need to look at the shoulder. Because what happens if the person comes in, my shoulder's killing me, you run them through back rack short overhead, and they pass all of them, or they don't have any pain with all of them. What bothers them and what they fail is bottom of lunge and crouching chain. Now that person came in with shoulder pain, I'm not jumping straight to a shoulder assessment. I might be assessing the opposite hip because of what I saw somewhere else. Because if we go back to spiral lines, go back to lateral line, the hip, either opposite hip or same side hip, can have a huge impact on what's going on with that shoulder. Like I said, if you have to stop because of pain, if you were able to see all of the criteria and make a determination, determine pass fail. If you weren't able to see all the criteria, just don't force them through it long enough to see all the stuff they chose to stop. Just fail them because you can't confirm that it's there. But pain doesn't automatically mean they fail. My shoulder hurts. Do you want to continue? Yeah, I'm fine keeping going. We're not going to fail that person because they said they were fine. They were comfortable. We can move forward until they tell us that we can stop. I had several patients that have met all the criteria, and you will run into patients that meet all the criteria for the shape, but they also have pain. Do you think at that point, if somebody passes a shape, but they tell you that it's uncomfortable or doesn't feel good, are you thinking structural issue? Probably not. Which again, as soon as we start to have that, it starts to prioritize what's coming next. Special tests aren't completely off the table, but we're moving down the list of importance of those special tests. Gotten this one a lot. Well, if somebody's in pain, why would you give them the opportunity to continue? Because pain and nociception aren't the same thing. Pain is a very subjective experience. If I were to have Callan come in here right now, set him on the table, and any of you took your hand and you put it on his quad and gave about 4 pounds of pressure, he would come off the table. Is that pain? To him it is. We put the rest of us on the table and we apply the same force. That's uncomfortable. Is that painful? Pain is a subjective experience. We each experience pain differently. So now if they have pain, because it is a subjective experience, I'm not saying they have to continue. We're giving them the option. Hey, this hurts. You're the only one that knows exactly what this feels like. You're the expert of your body and how it feels. With what you know about your body and what that feels like, do you want to continue? Now, we don't ask that whole question. We shorten it down to, do you want to continue? If you don't, that's perfectly fine. We'll go on to the next thing. If they say for them, this is too uncomfortable, it's too uncomfortable, we move on. It's their choice. Pain isn't nociception. Nociception, we have a direct insult to those pain receptors, to those nociceptors, that is sending a direct input to the brain that something is wrong. That's not always what pain is. Remember, pain is subjective. Pain could be either, nociception is always an input. Pain could be an output from the nervous system. So because of that, we're giving them the option to continue or we're giving them the option to stop. It's 100% up to them. When should I use the shapes? First and foremost, on your comp, because that's what we're starting with. We're assuming on the comp that this is a person who's coming in with no mechanism of injury. So they come in and that's that person. My knees have always hurt. I've got bad knees. My hips have always bothered me. My back started bothering me about a month ago. I don't remember what I did. It just has progressively gotten worse, or it's progressively staying the same. Every morning when I wake up, it's sore. It gets a little bit better as the day goes on. When did your back start to bother you? I don't know. It just hurts. I mean, that's what you're going to get if you're dealing with a high school kid or a college kid. My knee hurts. What'd you do to it? I don't know. How long's it been bothering you? I don't know. Did you do anything to it? I don't know. This is it. Okay, you don't know a lot of things, so we're going to start with this and get some actual solid data points. And we're going to run through the profile. As you're transitioning in rehab, and we have a lot of these transition points. You have somebody that's wanting to go back to ADLs. I need to go back to work. how are we going to determine if somebody's able to go back to work? Well, first we need to know, well, what does work consist of? A lot different if you're a construction worker versus an office worker. We can run them through here. Right now you have an athlete that has been out for whatever reason. What do you use to determine if they can go back to running? Well, it's been 8 weeks. You're good to run. That's the reality. 8 weeks isn't always 8 weeks. 8 weeks is a very different experience for a lot of different people. And if time is the only criteria that we use, that's just a true flip of the coin. That's not a professional decision. That's just it's a calendar. Google can give us that information. Same thing with returning back to throw and returning back to sport. Typically, when we get back to sport, we have some other things that we look at, and we usually do incorporate movement a little bit, as well as range of motion, some strength stuff. But the shapes give us a little bit, we can be a little bit more precise in some of the questions that we're answering. Because again, we're looking at should they or shouldn't they. Advancing in long-term rehab. You have that post-op patient, post-op ACL. That's at least a 6-month rehab, even in an accelerated program. For some people, that's a 12-month rehab. At some point, you're going to have to advance them to doing things at home on their own. How are you going to determine what lifts they can do at home on their own? Or you're moving forward and, I think it'd be really good to start deadlifting with this person. How are you going to determine whether you should deadlift with this person? Well, knee flexion's good. We're going to deadlift. 6 weeks out, we're going to deadlift. Should they? I'll stand behind my decision of yes or no, they should or shouldn't off of the shapes. If yours is just based off of knee flexion and knee extension, I'm a lot more comfortable in my position if something goes wrong than if something goes wrong in your position. Especially if we had some restrictions that we're dealing with. Long-term rehab, those are typically post-op patients or some kind of significant trauma that keeps somebody off for quite a bit of time. If you want to add any kind of stress to movement strategy, you've progressed in rehab, and you know what? We're going to start doing deadlifts. We're going to do back squats. We're going to do Bulgarian split squats. It's time to start jumping. Again, this can give us a little bit more information to make a better decision. I would hate to think how many hours I spent trying to coach people into a good deadlift, when if we would have looked at the bottom of deadlift shape, we would have seen right away that they failed. I have tried to outcoach that bad position. You cannot outcoach a bad position. You cannot outcoach what that person's nervous system is wanting to do. If we decide that we're going to deadlift with this person, and we have them standing over the bar, and they're standing over the bar like this, there is no coaching that you can do to get them into good alignment to pick that bar. Now, we can feel good about ourselves, and I've done this a lot. I need you to widen your hands out a little bit. Oh, sorry, okay. Can you shift your weight over to that right side a little bit? Yeah. Now, can you flatten your back out a little bit? Yeah. That looks awesome. You ready to deadlift? Go. They're going to go right back to what's normal for them. Because we didn't fix the problem. Those things that we tried to coach them out of were the red flags, the cues that they shouldn't do this. And we let our ego try to coach them into a good position. Because we blame the position. Well, I can fix the position. The position is not the problem. The position is what the nervous system is showing us. And we have to keep in mind, what the nervous system is showing us is the best that they can do in that situation. It's just, the easiest way to think about it is a test. Your final in this class at the end of the semester, it's going to be the best that you can do on that test. Some of you might get an A, some of you might get an A minus, some of you might get a B, some of you might fail. But it's the best that you can do right then and there. It's the culmination of everything we've done this semester. Now, the better we've done, the better I've done as an instructor, the more time that you've dedicated and invested into paying attention to study and to do all that stuff, when we get to the test, you're going to do better. But if you just show up, you don't listen, I show up, I don't do what I'm supposed to do, we get to the end, we can't be surprised when we fail the test. We know that fail the test, the problem was way back here and all of these other things. It's not with the test, because we all know I write perfect tests. I don't have any spelling mistakes, I don't have any confusing questions. None of that. It's never the test. Maybe that was a bad example. It's never the bottom of deadlift that's the problem. The bottom of deadlift is just telling us that this is the best they can do with what's going on. If they can't get exactly where we need to figure out why that's the best. What's going on with their body that's causing them to do what we're seeing, which is why I have to investigate things a little bit further. Finish the profile. What's the next step? Why is this important? Because fast forward to the week before spring break, you just ran that person through the critical shapes profile. What are you going to do next? I'm going to Disney World. You now need to take a second to reflect. What did I just see? What's consistent? Did every time I asked him to straighten that left foot up, or did I have to ask him every time that left foot needed to be straight, did I have to ask him to get that left foot straight? You're looking for, and going back, was there a consistent criteria that is in multiple shapes that they failed? Did I have to coach them on this? Did every time I wanted their back to be flat, did I have to coach them out of a lumbar flexion position? Was it always something at the pelvis? Was it always something at the ankle? Was it always something at the shoulder? Was there pain? Did I have to stop? Was there consistently a discomfort? This is also why I'm going to remind you guys of this as we continue to go forward. When you finish running somebody through the critical states, the critical shapes, the next thing you need to do is stop and don't do anything for 2 to 3 minutes. What am I supposed to do in that 2 to 3 minutes? You're supposed to go back. What did I see? Was there a consistency? What was the biggest thing that stood out to me? Did they always miss the same criteria? Did I always have to coach them on the same thing? You're looking for that biggest, that most obvious, that most consistent thing. And you need to take that. I can tell you, in the history of the comps, whether we were doing it with the FMS, the SFMA, or the shapes, we've always said, when you finish, whatever the test is we're using, when you finish, take 2 to 3 minutes. I can tell you 100% of the time, those people that finished the test and immediately went right into the next thing, always got to take their comp over again. If you blow through that stop sign, just like when you drive, you blow through the stop sign, we're going to run into some problems. You have to take that 2 to 3 minutes to gather your thoughts. If you do that, wonderful. If you don't do that, I can promise you, you're going to fall into the same category as everybody else has done that before, because you don't have enough information, you just want to keep moving forward. Take a minute or two to think. All that makes sense. Any questions about that? Remember, with the shapes, what we're looking at, all we're doing with the shapes, you could ask a person, I want you to stand with your foot up on the table just like this. I want you to externally rotate that. I want you to take this hand, hold it down like this, and take this hand, hold it down like that. We could come up with criteria for this position, and we could call this the foot on the table position. We come up with the criteria for this, and we look at this. I can't think of many times during the day I'm going to do this. Maybe when I'm tying my shoe, but not with the dowel. We can put somebody here, we can look at the criteria. We can determine what a criteria is for pass or fail. And then we can put them on the other side. See if I can recreate that. There we go. We can look at criteria for pass or fail. It doesn't matter what this shape is. We have given the body a task. We've given the body a task, a position to get into. We've asked the nervous system to solve a problem. And the problem is, I need you to put your foot on the table, externally rotate your foot, hold the dowel and not fall down. That's the problem the nervous system has to work out. How it positions the leg, how it positions the arm, how it positions the trunk, what it does on the opposite leg, what it does with your head. The movement outputs that our body puts together to accomplish that is the best our nervous system can do. If on one side, you see I can get full external rotation here, we do the other side and that's as far as I got, this is the best my body can do in this position. Maybe it's because there's some tightness going on here. Maybe the reason I can't externally rotate is because I played 3 hours of basketball yesterday because we were all iced in, and that hip's a little tight and that's as far as I can go. We don't know that. All we know is that there's a difference. So we have to keep in mind that these shapes, these setups that we're putting the body in, We're creating problems for the nervous system. And what the body shows us is the best solution that that nervous system can come up with at that point in time. We're looking at how the nervous system solves problems. And then all we're doing as we run through all the 6 different setups and shapes, we're just looking for consistencies. We're looking for, do we run into problems in how the nervous system is solving the situation that we put it into? Go back to elementary school, the multiplication tables. I don't know how you guys did it, but I know Mrs. Buffman in 3rd grade, she would give us the paper. You have 60 seconds to do as many math problems as you could. And if you did as many math problems as me, you got extra math work because you got to go to the special math group because you were a math moron, because she said I didn't do it. I think she was wrong. But 1 times whatever, nailed it. 2 times whatever, nailed it. I had the 5s. But as soon as I saw 3 times 7, you might as well have written it in hieroglyphics. Idiot. Anything. I couldn't do the 3s. Guess what we spent time working on when I went to the special math classes? We didn't work on the 2 times whatever tables. We didn't work on the 1s or the 5s. We spent all of our times working on 3 times 3, 3 times 9. And here's the thing. I still don't know what they are. Didn't work. But they identified the problem. We didn't work on all the multiplication tables. We just worked on the 3s. We don't need to look at and assess all the different joints of the body, but the consistent thing we ran into is the hip. The nervous system couldn't solve the hip problem when we engaged the hip. We need to look at the hip. So that's why we're going to start with the profile first. Thursday when we come back, we're then going to talk about what the next steps are. We've taken those 2 minutes. We've determined that I need to look at the knees, or I need to look at the shoulder, or I need to look at the low back. What are our options at that point in time? And we'll also talk